Hello, everyone. My name is Braden Van Alfen. I am a senior at Brigham Young University, and our study is on hip and knee kinematics in an older, healthy population during therapeutic exercise. So our goal of this study is to characterize lower extremity motion during two common exercises that are used in post-TKA or total knee arthroplasty patients, and that is the straight leg raise and a knee flexion exercise. And it's important to note that this is the first part of a multi-part study where we will compare this data to the same exercises in a patient population that has recently undergone total knee arthroplasty, as well as to create a novel and inexpensive sensing system that these patients will be able to take home with them to do the exercises that will give them biofeedback on how these exercises are going, and also so that the physical therapist and physicians will be able to see the same data. So we looked at 20 healthy volunteers, 10 male and 10 female, in a motion capture lab using the Qualisys program. We attached reflective markers on bony anatomical landmarks on the hip, knee, and ankle, and then trajectories were used to calculate 3D hip and knee joint angles. And each subject, and for each exercise, they did five trials, and the middle three trials were averaged and then time normalized for each subject. So here are the results. And the first two graphs that we might look at are first the straight leg raise, the hip angle, and the sagittal plane here. This is going to be the major joint movement throughout this exercise. And we see a fairly standard and uniform pattern as they increase in flexion and then come back down into extension. There are going to be some differences in the level of flexion. So as we instructed them to go about the exercise, we instructed them to stop once they're flexing leg, once that knee was the same vertical height as the knee at rest. And some just continued to go further. And so that's going to account for the major differences here in max flexion rather than a range of motion thing. And then with the flexion exercise, the knee angle and the sagittal plane is going to be the major movement. And again, fairly uniform, fairly standard here with both. And with all the graphs, you are going to have a lot of variance in the time that they took to do the exercise. And most of that is just going to be personal preference as far as their speed that they went throughout the exercise. So if we continue on and look at this hip angle in the frontal plane for the straight leg raise, it's interesting to note that a lot of them were more adducted at the hip and some were more abducted here below 0. And that's just important to note because we didn't control for this, didn't tell them exactly where to be. Some just were slightly more medially, slightly more medial, and others were slightly more lateral. And then we're going to see a similar variability in the knee angle and the sagittal plane, but mostly for different reasons with the straight leg raise. So here below 0 on the y-axis, you have couple people who are hyperextended the entire time throughout the straight leg raise. And that's significant because that is a sign of strength in their quads, that they are able to keep themselves in hyperextension as they flex their hip and go about the straight leg raise. While others are going to be more in flexion the entire time up here as a sign of weakness in their quadriceps. And then it's interesting to note there's a subject here that starts right about 0, and as their hip flexes, their knee also is going to go into some flexion before going back down into extension at 0. And so it's just important to note that even in a healthy population, there is a lot of variability in strength and the way in the trajectory that they're following throughout this exercise. And we're going to see a similar thing in the knee flexion exercise with the hip angle and the transverse plane. You're going to have some people who are more internally rotated and others who are more externally rotated down here. And this could be a difference in small anatomical differences. So a little more anteversion up here with the internal rotation, and then a little more retroversion at the hip with some of the more external rotation at the hip. So small differences in anatomy may make a difference as well. And then this last graph is just going to be correlating with this graph over here, the knee angle and the sagittal plane for the straight leg raise, just showing the max difference in those angles. So like we mentioned with the variability, even healthy subjects have a lot of variability. And some of that is going to be functional range of motion due a lot to strength, and then slight anatomical differences may make a small difference as well. And this current data will guide post-TKA patients through their exercises. So they'll be able to receive immediate biofeedback and see where they can improve, what is different, and what to focus on in order to return back to full function. So as we compare the data between these healthy subjects and post-TKA patients, we'll be able to see what is different and identify biomechanical factors or patterns that may yield improved function or more rapid return to function. And we wouldn't be looking for one very specific trajectory for them to follow, but there is this range that healthy subjects seem to be in, and we can shoot for that same range for the subjects. Thank you for your interest in this study, and I'd be happy to answer any questions that you have.